I saw several questions with people about the shingles vaccine. So, if somebody's already gotten the shingles vaccine, or can they get shingles? Alan was asking that question. And then, if they've had prior therapy, like, okay, transplant or things like that, should they be doing something additional for shingles? How often do you do this? After what therapies? Those kinds of questions. Jeff was asking that question.
Those are all really good questions. And, what we know about shingles, what we know about Shingrix, which is the preferred not live shingles vaccine, is that it's effective in older patients. It's even effective very soon after autologous transplant. What we don't know is, okay, if you've got Shingrix and you're on 3-drug therapy for the foreseeable future, are you still at risk for shingles? We really don't know that. To my knowledge, that has not been reported. And so we often, or at least I often recommend that patients who are on single drug Revlimid maintenance, if they are a year or more out from transplant, if they get a Shingrix vaccine, they can stop acyclovir. IMiDs are not known to significantly increase the risk of shingles, and hence, if you're more than a year out from transplant, have received the Shingrix vaccine, you can stop the acyclovir. All other myeloma patients in our practice tend to get some dose of acyclovir. And in a relatively large retrospective study that we performed, we found that basically any dose of acyclovir prevented shingles in those patients who are not within the first month of diagnosis. And the only people we saw getting shingles are those people who stopped acyclovir completely. So I think if you can wrangle patients who are on multi-drug therapy who really don't want to take continued acyclovir to take at least one dose a day, that will significantly decrease risk.
Mm-hmm. Do you need acyclovir after CAR T?
Yes, CAR T is significantly immunosuppressive in the I know that BCMA-based CAR T therapy in myeloma patients is significantly immunosuppressive, and therefore these patients are continued on with acyclovir. My patient who stopped acyclovir 6 months after receiving CAR T, he got CAR T as part of first-line therapy after autologous transplant. Mm-hmm. And 6 months after that, he thought, well, my myeloma is in remission, I'll stop all my other medications. And then unfortunately developed shingles, which involved his eye. And then he had to be admitted, was on IV acyclovir, and fortunately did well. But CAR T therapy can lead to relatively prolonged immunosuppression.
Mm. And Dr. Lynch, please, I want us to go back and forth on these questions. So,
Greg covered that really perfectly. What I want to point out is take the Shingrix vaccine, but don't rely on it, because the issue is that antibodies are produced by plasma cells. When you get myeloma treatment, you wipe out the plasma cells. And we don't even know whether you, first of all, build up immunity after the Shingrix vaccine that is sufficient. And number two, what happens with the antibodies? So I would say acyclovir, it's so easy to take. And it has almost no side effects. Make sure that you take it adjust that to your renal function. But having really shingles, this is not a good thing to have. So I would say final is don't rely on the vaccine. It's good, take it, but don't rely on it.
Yeah, that's really good advice. Okay, and Ken was asking kind of a follow-up question. Can the Shingrix vaccine be used for somebody who's had allo transplant?
I think that needs to be discussed with an allo transplanter, but if you are out of the allo transplant, absolutely, yeah. Mm-hmm. So I'm not exactly sure with the allo transplant what would be the right time to revaccinate. I guess it's probably the same with an auto transplant. And I think also, yeah, you need the Shingrix vaccine for the allo patients too. Greg, what do you think? That should be the same principle.
I agree, and we tend to at Emory recommend the Shingrix vaccine a year out from both autologous and allogeneic transplant. Of course, it's going to be harder for those patients who are on tacrolimus or other immunosuppression after allogeneic transplant. It's hard to really advocate to stop acyclovir in those patients, but if they have no GVHD and are not on any immunosuppression, absolutely.
Mm-hmm. Okay. And just to note, I think you reviewed this already, but Shingrix is the dead vaccine, not the live vaccine, right? So everyone just pay attention to that. Don't take the vaccine. We did a survey with Dr. Thompson, and he was asking what kind of immunizations patients had received, and some patients had gotten the live shingles vaccine, which is not a good idea. So don't do that. Okay, let's go to a little bit on neuropathy. I may not group these appropriately, but let me try the best I can, because you both did such a nice job. For neuropathy, Dr. Hoffmeister, you said that neuropathy is one of the things you don't want to have. So at what point as a patient do you just say, hey, time out, like I'm having some severe issues and I don't want it to get worse? Because I've had some friends who just let it go and let it go. Oh, this is like, as patients, I think we look at it like, okay, I have to be, obedient to my doctor, and I have to take this medication. I want it to kill my myeloma. And what's the timeout point for you?
Right. And literally, I've had the same unfortunate experience where a patient could not walk before they finally admitted that, hey, I have really bad neuropathy. It is heartbreaking, but it needs to be, the majority of patients who are getting Velcade are early, they're getting first-line therapy, and the time when I want to know is when it's no longer intermittent. If you have tingling that's constant or anything worse than that, that, in my view, necessitates a change, especially with the idea that there are other proteasome inhibitors that are not associated or associated with less neuropathy. You got to have that discussion. So if you have intermittent tingling and it's occasional and you're not really sure, and maybe, okay, I don't mind letting that go on. But if you have tingling that is constant, certainly if it's numb, even worse if it's painful, we got to stop, because you never know when you have the unfortunate situation where the Velcade that you have received already comes calling and causes worsening neuropathy even 2 months later. And I've had the unfortunate episode where a patient got 3 or 4 cycles of Velcade before they even started developing neuropathy, and then they got neuropathy so bad they couldn't walk. So it's a terrible thing. I try to avoid developing neuropathy, as prevention is so much better than treatment.
Mm-hmm. Usually what I try to do is I try to figure out what is a baseline neuropathy, because many multiple myeloma can be associated with a baseline neuropathy. In order to really, I think we need always the patient. Myeloma is a disease where you cannot treat just based on an X-ray. You need to discuss with your patient, say, tell me, can you figure out what could you do in terms of closing, using buttons or writing or work that really needs the fine motoric. What could you do before? What can you do now? And is there worsening? And if there is progression in that neuropathy, then I think this is a red flag. If it gets worse and worse and worse, that's a red flag.
Mm-hmm. Okay. Kind of a follow-up question to that Natasha has said. So she had 7 cycles of Velcade, 1 injection a week. And by the way, there's the IV version that you mentioned, and the injection version. You should just do the injection version, right? Because lower neuropathy. But just stayed on Revlimid, and now the neuropathy seems to be getting worse. So is that caused by, does it have anything to do with the Revlimid? Is that like what you're saying, Dr. Lynch? The myeloma itself can cause neuropathy, or you can so what is this? I know you can't answer specific patient questions, so I would ask patients, in the chat and everything, kind of ask a broad question if you can, and not necessarily a personal question, but I think this is interesting.
I don't know. Greg, it's always good to discuss with the colleagues, you know. So Revlimid should not induce neuropathy, but I have to say I had few patients who developed neuropathy with Revlimid. So I would try to pinpoint when did it occur, was there any event associated? And if the patient is able to really pinpoint and say, yeah, it's getting worse despite my Velcade stopped 6 months ago, then I think you also have to change to Revlimid. Make sure it's no other factor, no other medication that causes neuropathy.
Mm-hmm. I agree. I've had a couple patients with Revlimid that have Revlimid-related neuropathy, and Revlimid-related neuropathy is an entirely different animal and usually seems to be filled with self-doubt, both in the physician and the patient. And you're like, well, do I really have it, etc.? It just seems to be a much slower onset, but still can occur. I just see it so rarely.
But remember, thalidomide caused really bad neuropathy. Yeah, that was bad neuropathy. So I think there might be a component in very few patients, and I don't want to be an alarmist, in very few patients, that we should not brush off as a patient if a patient comes with that complaint, so that we listen and say, you know, it might be the Revlimid.
Mm-hmm. Interesting. Yeah, I had both thalidomide and Velcade and developed that. And I think what you were saying earlier, that the thalidomide was longer term, because I still have some of that. So Todd is asking a good question when it comes to neuropathy. So let's say you got treated with Velcade in your initial therapy. You got a remission. You had some neuropathy at that initial stage. You need to get treated again. Do you consider reusing it even if you had some? I mean, this kind of goes back to, you know, your question about the levels of neuropathy that you had and did it go away? But what do you say to patients who are doing the second line of third line, fourth line of therapy about reintroducing Velcade when they have some neuropathy?
You know, in general, for me, I will consider Velcade in somebody who has neuropathy if my back is against the wall and there's literally nothing else. So, you know, if I can't use Kyprolis, and I dislike using Ninlaro, which I do, you know, those are the patients at which I'll consider using Velcade again. But again, this is something I really don't like doing. It feels terrible to do it, but sometimes you're just forced into a box.
I completely agree. You know, I would not go back to the same drug if I'm not forced to do this, because lack of other medications, insurance, whatever reasons. I don't even recall a patient in the last 10 years I had to go back in the second line treatment to the initial treatment. We have so many more options which do not have that risk of neuropathy. So I would say in general, no, I would not go back.
Okay, so you would think about Kyprolis or something else, or Ninlaro or something. Okay, well, this is an important, concerning question for myeloma patients. I do want to bring it up because you are both experts. And Nolani's asking, what are your opinions of the COVID-19 vaccines for myeloma patients? So it's been so highly politicized. This is, to me, a medical issue. And I think it should stay medical, whether you get the vaccine or don't get the vaccine. And we should be basing our decisions on data or your experience. Like, what is your opinion about that? And someone else asked a question that I saw in there about seeing some, you know, in the early first the first couple days, a few people in the UK had allergic reactions. And so should that be considered? So, like, what do you think at this point in time with the lack of data that we have?
Yeah. So as you pointed out, Jenny, there are no data. So I can only give you my very personal opinion as an old myeloma doctor. So number one, I have to say, with all criticism, we are in this country in a good position that we have not enough, but more vaccines than other countries. You know, as you can hear, my accent is German, so I'm coming from Germany. I'm following the German news. I don't know why, but there is a huge, I would say, kind of, you know, upsetness because the government didn't buy enough vaccine. So it's slow, but hopefully we will have enough that everybody can get vaccinated, I would say, in the first half year of 2021. If I can get the vaccine, I would take it right away. I would do whatever I can. Unfortunately, even being a healthcare provider, being on the forefront and taking care of COVID patients was not in the first, I would say, kind of, batch of doctors receiving that vaccine. ED physicians, nurses, workers in the ED, I think they have a much higher need to get the COVID vaccine. I would take it. I would recommend it to all myeloma patients. Yeah, there are some side effects, but the side effects or the, I would say, allergic reaction can occur with each vaccine. It can occur with all the substances you eat or you drink or you get as an injection. So I would not be too concerned about that. The principle of a vaccine is pretty easy, that you get pieces of an RNA and we have so much RNA pieces probably ingesting into our body for other reasons that I wouldn't be too concerned about that. We have to take that serious, but the vaccine is good. The other issue is we don't even know whether our patients who get myeloma treatment will build up immunity when they get the vaccine. That's, I think, is a much bigger problem. If you can get the vaccine, take it, but will you really build up antibody? Because we bombarding your B cells, producing the antibodies with dexamethasone, with Kyprolis, with all the treatments we have. So the problem is, even if you have the vaccine, you might not have a protection from it.
Mm-hmm.
Right?
Yeah.
And I agree with everything my German colleague said, and I make a joke about that just because I got a German vaccine this morning. The Pfizer vaccine really is not Pfizer's vaccine. It started from German scientists who I have to thank for the vaccine I got, and I just tweeted out my recommendations is that vaccine, when they reported on the first, however many, 37,000 or 45,000 patients that received it, the percentage of patients with any malignancy was 4%, but the number of patients with lymphoma was essentially 0. Number of patients with metastatic solid tumors, 0. So we know that myeloma is a very immunosuppressive cancer. So I'm not worried that myeloma patients are going to have a significant side effect. I'm worried that it won't work, as the mRNA vaccines want to use your immunologic machinery to make the immunogenic spike for which we want to have that exposure. So, but I make it clear to my patients that if they should come across somebody willing to administer them the Pfizer or Moderna vaccine, they should sign up and get it.
Okay. Well, thank you for those answers, because it's hard as a patient for us to make any kind of recommendations at all about what patients should or shouldn't do. We always say, go ask your doctor and have that conversation with your doctor. That's the right approach. So, and be kind to others who are, thinking about this differently. Take it or don't take it, but be kind. So, yeah, that was one of Tracy's questions. Okay, so a question about replacing Velcade, not with a proteasome inhibitor, but maybe some other kind of therapy. And you kind of mentioned this before, because Leo's a professional musician, and the doctor at UCSF is highly suggesting to use daratumumab instead of Velcade. So that kind of would be your suggestion, it sounds like, from your earlier answers, right?
Yeah, I have a patient who is an interventional cardiologist. So he is trying to opening all your vessels around your heart, which needs a lot of, I would say, kind of, fine motoric and really sensibility in you. So we agreed, I never gave him really any kind of proteasome inhibitors. I didn't give him Velcade, and didn't give him ixazomib. And I started daratumumab Revlimid, and he was fine with it. Yeah, so I think that's the good alternative if you really depend on, I would say, the sensitivity in your fingertips, and you cannot even have a risk to try it.
Mm-hmm. Mm-hmm. Okay, good. So Dr. Hoffmeister, you talked about the side effects of the bone strengtheners, Xgeva and Zometa. Are the complications and side effects, Meryl is wondering if they're similar And Dr. Lynch, you had done a prior roundtable with us talking about stopping Xgeva, and I just want you to comment on that after Dr. Meister comments on that.
You know, in general, I think that Zometa and Zometa, you know, I think that Zometa still has more flu-like illness properties than Xgeva does. Xgeva can cause more low calcium levels, and patients can have side effects from both. And it's really hard to attribute exactly what it was about the vaccine, about the Zometa or Xgeva that caused the side effects. You know, in general, we tend to use a lot more Zometa than we do Xgeva because the cost differential and the history of general safety with Zometa that we have for a longer period of time than Xgeva, and tend to stop using the medications once patients have achieved a very good partial response or better.
Yeah. I think the mechanism between Xgeva and Zometa is different. And I agree completely with Dr. Hoffmeister. We are so used to give Zometa. We extend the intervals if patients don't really have bad bone disease and have a controlled myeloma to every 3 months. There are studies that have shown that 3 months is equivalent to a month. And if you have a controlled bone disease and not hypercalcemia, the costs are much lower. You have to keep attention to the kidney, but what I wanted to bring up is that Xgeva is kind of it takes the food for the osteoclast away. It blocks rank ligand, which the osteoclast need to function. So the osteoclasts starve without the rank ligand and stop to have activity. So when you stop Xgeva and rank ligand is available, the osteoclasts are so hungry that they, I would say, super utilize rank ligand and have an overshooting activity. It's like when you are very hungry and you are allowed to eat and you have suddenly food, you eat so much you cannot even control it. This is like with the osteoclast. So once you stop Xgeva, the rank ligand is available. There's an overactivity of the osteoclast. And what we observed, and that was especially data from our colleagues from endocrinology who used a lot of Xgeva for osteoporosis, that you have the atypical fractures. So you have an overactivity of osteoclasts causing damage again. And what you need to cool down the osteoclast, you need at least before you stop Xgeva, have an overlap, for instance, or a couple of months of Zometa. I'm concerned that I might forget it. If patient stops Xgeva, I forget to give Zometa. And then maybe we have an atypical fracture, not due to the multiple myeloma, due to the overactivation of osteoclasts. So I shy a little bit away from Xgeva because of that side effect, which can be serious.
Mm-hmm. Okay, that's really good to know. We do have a roundtable on that with a little more information about that. So when we share this one, we'll include that link as well. We have some patients have some follow-up questions, like where do they get the COVID vaccine? Do they get that from their myeloma doctor? Do they get that in another clinic? Like, is there a difference between the two vaccines? My guess is not that much, but maybe. I don't know that much about it. Can you address like when patients should get it and where should they go get it, if it's possible for them to get it?
Greg, you have any information? Because I don't.
Despite being in the same state as the CDC, I still don't have great information. I know the state of Georgia got something like 45,000 or 85,000 doses of the vaccine. A lot of it, those initial doses get sucked up by high-risk folks in nursing homes and, you know, what is thought to be high risk in sort of COVID-facing folks, especially anyone who's associated in the emergency room or in a COVID unit. Those kind of make sense. After that, I was asking everyone who would tell me where could I get the next vaccine. One of my patients works at the CDC, of course, so I'm anxiously calling and texting her all the time, saying, when do you think? What do you think? When's it going to be available? And she is hoping that there'll be more vaccine available for general consumption in approximately a month, which I thought was very positive, even though the next month is going to certainly be deadly.
But Jenny, just and for all patients who are listening, I mean, we as myeloma doctors, we know that our myeloma patients and also lymphoma patients really need the vaccine. So we would fight for our patients. And the only concern is, and I just want to mention this, that if you're on active treatment, the question is, should you maybe wait until you are done with the treatment and get your vaccine? It really depends how much vaccine do we have. Is it a once in a lifetime shot and there's not enough, When is the best timing to get the vaccine? Maybe after you completed your DEX treatment, because it's antagonizing, The DEX wipes out the B cells producing the antibodies or makes them lame, and you get the vaccine. Per insurance or community, you are done with your one-time shot, so that's it, and you didn't even have the ability to build up antibodies. So I'm just kind of, throwing that out. I mean, try to get it, but it should be a good timing and discuss it with your doctor.
Yeah. Yes, again, please go talk to your doctor about it. That's such an important point. Like, yes, is it going to work and be maintainable for you or sustainable for you? So very important. Someone is asking a question about headaches and the side effects of Velcade, Revlimid, or Dex. What do you typically see if somebody presents with a headache? Are there any specific drugs that cause headache?
I would say no. I wouldn't say that the medications you mentioned are typically associated with headaches, but a headache is such a common thing and it can occur so often. What I would do as a doctor, and I'm very generous, I would probably see, are there any reasons? And the first thing I would start with a CT scan. If the headaches are not the baseline, how was it before, any changes? To rule out bleeding, for instance, infection, that's the next step. But first thing would be to rule out, for instance, a tumor or infection. I wouldn't think about myeloma in the brain. That's very rare, an extremely rare effect. I would just kind of, make sure that there's no bleeding.
Okay. Dr. Hoffmeister.
I always think about sinusitis. And even though sinusitis generally, is certainly not a mystery, you usually know what's happening. The patient will all but scream out, hey, this is my sinusitis causing this. Sometimes it's hard to treat sinusitis, and sometimes, especially immunosuppressed patients, it's difficult to get proper flow and bacterial clearance. So I often think about that. I have had patients who have uncontrolled myeloma bone disease in their skull and their calvarium, which leads to headaches, but that's the distinct minority.
Mm-hmm. Okay. Dr. Lynch, you talked about a lot of CAR T-cell therapy. You were showing curves about benefit and things like that. Adrian's asking, how long after BCMA CAR T do you obtain the maximum anti-myeloma benefit? And then Dr. Hoffmeister, you kind of mentioned that you might be immunosuppressed for a while. So how long does that immunosuppression last? I'll let you both answer those.
Yeah. So talking about CAR T cells, and I talked in general about CAR T cells because the principle is the same. You can use a T cell out of your body and you can modify it that it binds to either BCMA or CD38. There are many more targets for multiple myeloma that CAR T cells can bind to, and maybe in the future we will have multiple targets. Like we combine, for instance, an IMiD with a Velcade. Why not combining in CAR T cells that targets BCMA and maybe CD38 or other targets? So that's number one. The principle of the CAR T cells, and that what we were hoping was, you take the T cells out of a patient, you modify the T cells, and you give the T cells back to the same patient. So the T cells should recover and, best case scenario, proliferate and stay for good in the body. That means if a myeloma cell occurs, the T cell that is kind of targeting or specifically binding to that myeloma cell can kill it right away. The disappointment in multiple myeloma was that, in contrast to lymphoma, where we see that proliferation of T cell is ongoing and the patients are cured, with a limited follow-up we don't really see that in multiple myeloma. We see that the median progression-free survival, that means until the myeloma comes back, is 8 to, I would say, 12 months, depending on the CAR T cell. So that's disappointing. We are discussing what is the reason. I think we all assume that if you take a lame or very inactive or damaged T cells out of a myeloma patient, you try to mobilize that. The T cell is not really a good job. It's like you're on a wheelchair and you try to, with some doping, to make a marathon runner out of that person. So I don't know if the comparison is really true, but I think in general, with the CAR T cells we have in multiple myeloma, progression-free survival 8 to 12 months, and we don't see a plateau. That means it's further going down.
Mm-hmm. Okay, great.
And as for immunosuppression, there are patients, at least the patients that I've had that were relapsed and were on the BMS trial, there were a proportion of them who had prolonged pancytopenia, which means low white cells, red cells, platelets, and they're somewhat transfusion dependent. Those patients seem to be more immunosuppressed than other patients who've had a CAR T and their counts recovered.
Mm-hmm. And how long? Like when you said your patient was on acyclovir and stopped after 6 months, like how long would you keep a patient on acyclovir or other supportive medication?
Again, this is not a popular answer, but I generally, when I meet people, if there was a lifetime membership of acyclovir that I want you to take, anyone over 50, I want you to take acyclovir forever if you're a myeloma patient. But again, I have a very strong view, and I'm not paid for by those makers of acyclovir. So we love acyclovir because it's everything we hope to be: cheap, effective, and almost no side effects. So for those that tolerate it, we love it.
Okay, a patient's asking. We've had a lot of questions also about IVIG in the context of immunosuppression, and some with COVID, some without. So can you just share your opinion of the use of IVIG? When do you use it? When do you not? Does it protect you against COVID? Does it not? I think that answer might be no, but you can elaborate on that.
So I have a strong view in terms of IVIG. I have to say I really like it, and especially in patients. So what is IVIG? So just for everybody, it's an infusion of immunoglobulins from a healthy donor. So you get the antibodies from a healthy donor. The half-life time is around 2 weeks. So you might lose the immunoglobulins after 4 weeks completely. That's why you have to repeat it in order to make it sufficient. When do we give IVIG? Usually two components decide. There's a quantitative level of immunoglobulins. That means if your IgG is below 400, that's something I raise an eyebrow and say, let's look kind of how the patient is. In addition, it's the age and prior infection. So I asked the patient, how many infections did you have last year? What I mean is infections really requiring antibiotics, sinusitis, bronchitis, pneumonia. And if the patient reports more than 2 infections in 6 months and has a low immunoglobulin levels, usually then I consider, at least for the winter months, to give IVIG.
Interesting. Okay, great. Another question on Revlimid causing neuropathy by Tony. So if you're using it in a triple combination as maintenance therapy, like with Dex and Dara, at what point do you just get rid of the Revlimid if you think that's the cause?
Boy, that's tough. I've never had that happen. I've never heard that happen. I'm sure I hope. I don't know. I don't know what to do. I would try lowering the dose of Revlimid first and seeing if that can slow it or make it or stabilize before dropping it. Revlimid does tend to prolong the durability of Dara's effect. So I'd love to have those two play together as long as you can, even at a low dose.
Okay. Robert asked some questions about, we haven't even talked about these drugs, but the combination of selinexor, bortezomib, and dexamethasone. Someone just started that and wants to know what kind of side effects they can anticipate. And interestingly, in that announcement they made yesterday, I thought it was interesting that using selinexor with Velcade reduced neuropathy. So do you both want to elaborate on that?
Yeah. I mean, luckily we have another drug approved for multiple myeloma. I'm not sure about the reduction of neuropathy, but again, I think it's a good option. Even if you combine selinexor, for instance, with pomalidomide or with Ninlaro, it's an all-oral option, which I think is an additional tool for us. I personally found selinexor difficult to give to my patients. It requires a strong interaction with the patient. Almost all patients feel kind of, they stop eating, stop drinking. So you really have to make sure that your patient is on Zofran, that the patient is drinking enough, because subsequently, if as a myeloma patients you don't have enough fluid intake, your kidneys might suffer. So usually what I do is, if a patient starts selinexor, I see the patient personally at least once a week, and I pre-schedule that patient already for some fluids, and make sure the patient feels well, because the early management during the first couple of months is important in terms of what is the appetite, nausea, and thrombocytopenia. I think those are the main problems with the medication.
Mm-hmm. Okay.
And the selinexor, the only other thing is that, the reason they say it lowers neuropathy is because it has nothing to do, again, with the selinexor. It's just whether you associate it with twice-weekly Velcade or once-a-week Velcade. And sure, you're going to get less neuropathy if you just do once-a-week Velcade. So I absolutely agree that once-a-week Velcade will be associated with less severe neuropathy than twice-a-week Velcade. And the interesting part from ASH this year was that selinexor at 60 milligrams weekly, when combined with POM and DEX, even in patients that were Pomalyst refractory, still showed some 35% response rate. And 60 milligrams of selinexor is not bad, meaning that 80 and 100 milligrams, 120 milligrams of selinexor, if you remember when selinexor was first being developed, is not easily tolerable, and dose certainly responds. And dose for selinexor increase is associated with side effects. It's also associated with effectiveness. So even at 60 milligrams, you can still get some effectiveness and many fewer side effects. So I thought that was one of the positive things from ASH.
That's super interesting. Okay. And that's one thing you can talk about with your doctor for the Velcade alone, right? Even so, weekly versus twice weekly. Interesting. Okay. Jim had a question on the COVID vaccine. I'm sorry to be jumping around, and we'll have time for about 3 more questions. But as Revlimid kind of gives you that, it's called an immunomodulator for a reason, right? It does something to your immune system to boost it. What's your opinion that a patient on Revlimid maintenance might be better prepared to fight COVID or respond to the vaccine?
Yeah. This is an excellent question. I wish I would have the answer. And I would say I don't know whether Greg has any data, but in the beginning, there was a lot of, I would say, questions behind the Revlimid. You can argue Revlimid induces T-cell activity, which is good. Your T-cells might help to fight infections. And I think somehow we see that with Revlimid a little bit. And I think that's a mechanism that the T-cells are activated and have a direct anti-tumor effect. That's why you also have the rash, or you have colitis, as a response or as a result of the T-cell activation. So, but remember, in COVID, you have that phase 1, which is the infection, and you have a little bit of fever, phase 2, where you have the pneumonia, and then you have the phase 3, which is a hyperinflammatory phase. So does Revlimid contribute to that hyperinflammatory phase? That might be also possible. So I was kind of, when Fosselbeck in the beginning, I think I stopped Revlimid and then I restarted it. I don't know, Craig, you have any data? I don't think we have really data. What is the effect on COVID on the effect of COVID?
I don't know of any data either, but I certainly do know that if you compare, as we have in a randomized trial, folks that got Revlimid versus those that got placebo, the folks that got Revlimid had more infections. So make sure that there's a lot of hand waving when it comes to T cells and NK cells and activation, etc. And I like to wave my hands just like the next guy. But there are more infections for the Revlimid consuming folks than those that aren't. So if that relates to COVID, I don't know. But just in general.
Mm-hmm. Don't stop Revlimid. If there is, for instance, many patients stopped their ACE inhibitors, losartan, because they thought that the virus might better bind to the lung cells or not. There were some conflicting messages. My message is, as a doctor, there are no data. Don't stop the Revlimid. We know it prolongs the progression-free survival. It prevents not completely, but to a higher grade relapse, and wear a mask. And if you have, wear an N95 mask. Protect yourself, but don't jeopardize your treatment.
Mm-hmm. Right. Two more questions. So one, some people are asking how you determine if you have become or you've responded to the vaccine, the COVID vaccine, if you get it. So that will be our next to last question.
Greg, you want to take it?
Oh no, this is all you.
You just check the antibodies. there are two things. You can check whether you respond to COVID. First of all, antibodies. That's pretty easy. You just take a blood and you see, do you have antibody against that RNA or that COVID proteins? Number two is, and we learned that there were many patients, and I would say not patients, or COVID infected individuals who had COVID. They were positive by PCR. They had either no or minor symptoms. And they didn't have antibodies, but they knew they went through a very mild form of COVID. And then what we did, and also other, I would say, universities, and there are publications out, we saw that they have very reactive T cells to different parts of the COVID protein. So the protection is not only antibodies, it's also T cells. So if you have T cells that are really, I would say, very active, and maybe remember that you have prior in contact with other coronaviruses, not our COVID-19, you might have also an immune response or protection just based on the T cell activation and specific response. Mm-hmm. But that's nothing, that's a special, I would say, technique. It's flow cytometry, and nothing that probably you can go to your doctor and say, hey, can you check my T cells, for COVID reactivity? That's something within, I would say, clinical trials.
Mm-hmm. Okay, great. Thank you for covering so many topics. We have one more question that I'll just introduce, just because it's such a common question about dexamethasone and sleep issues. I think, like I said earlier in the show, I was about 6 months into my therapy, totally kind of feeling psychotic and angry and having sleep issues and wondering what it was. And someone said, oh, well, one of my nurses, well, that's the Dex. Like, I should have been asking better questions. Like, do I have to put up with this? And like, when should I? Yeah, I had to take a sleep aid for sure. But do you want to talk about just how to best manage dexamethasone?
So, from my point of view, again, my view is not shared sometimes by many. My colleagues use a lot of Dex, and 40 milligrams of Dex a week is a heck of a lot of Dex. And let's remember that you get a better response at 40 milligrams of Dex a week. And if you do that for 4 days a week, you'll get an even better response, but you'll die earlier, and you will certainly hate your life. So there are folks like my father. He could take steroids and chew on them like M&Ms right before going to bed at night. Just have, however much you want it, sleep like a baby, no problem at all. But I think that many of my patients struggle with Dex and insomnia. I've never found a drug that works reliably on every patient. And so I haven't been able to get, oh yeah, this sleep aid will definitely work, as I've had many patients just roll right on through an Ambien dose for the entire night and call me pissed off the next day. So I tend to use lower doses of Revlimid for those that are intolerant. I quickly dose reduce because literally I've had patients who can't get sleep, are in and out, mood is bad, then they get up in the middle of the night and they fall and break a hip. And that is associated with clear mortality. So I think that in many, many patients, I have a more permissive view of 8 to 12 milligrams of Dex a week rather than 40 if they demonstrate intolerance. And Dex is the drug we love to hate.
Yes, it is.
Yeah. What I do is I think patients are much more relaxed if they know what's coming and it's expected. So when we start treatment, I tell the patient, listen, you will not sleep the first night. And I think that knowing what I experience is normal, and this is what my doctor told me, makes the patient so much more relaxed that they say, okay, and I tell them, maybe you can clean the house or do something else, but it gives the patient the feeling something expected is going on, it's against the myeloma, and let me deal with it. And I think that's important. We try to navigate around that, and I say, see what works. Sometimes it's gin and tonic. I shouldn't say that, but maybe taking Dex right before you fall asleep, that you have the full effect of the Dex the next morning. So that's, or reduce the dosage. That's play around with it. Try to be relaxed, because if you really want to sleep, you will not sleep. Take it at different times of the day. Maybe take the Dex, go to sleep, and at least get 4 or 5 hours of sleep before the Dex kicks in.
Mm-hmm. Okay, well, such good advice. And I think that key takeaway is talk to your doctor. Like, don't suffer with with side effects that you were not discussing with your doctor, because there's a lot, like what you were both saying as experts, there's a lot you can do. You can dose reduce, you can change the frequency, you can mix up combinations. So please, 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 if you are a myeloma patient, go and talk to your doctor about these side effects. I just want to thank you both so much for participating in your excellent presentations and the Q&A. If you want to stay on and answer some unanswered questions, you're welcome to. We will be sharing this. We had some people have some technical issues getting into the meeting, so we will be sharing this one on our YouTube channel later today, and we'll send everybody the link to that today. But we will also, we want to share something that we've been working on the HealthTree side, and that our product manager, Todd Foster, will share with us. What we learned is that patients themselves can share their information together and of what is working and what isn't working. But we want to, sometimes you'll post in a Facebook group, what did you do for neuropathy or something, and you get 5 or 6 responses. But we wanted data around that, like how well did it work and what was the average severity for these things. So I just want to thank both of you, Dr. Hoffmeister and Dr. Lent, for joining us today. Thank you so much. And with that, we will move on to have fun.
Thank you for having us. Happy holidays for all of you. Be safe. No COVID allowed.
Bye.
Yeah, bye-bye.
Thank you so much. Okay, Todd, I will let you take it away.
All right. It's great to be here with you all, and excited to show you our Side Effect Solutions tool. Some people are nervous about it, putting this information out there, but we're excited to hopefully help all of you with the side effects that you're experiencing. So I'm going to share my screen right now. This is what the side effect, when you first come into Side Effect Solution, it's an option over here on the left-hand side, Side Effect Solutions. And this is what the screen looks like. You can see a big long list of about 110 side effects. And you can scroll through them and click in and, look at anxiety. You can click on it. And, well, sorry, something's going on here. Refresh it. There we go. So we have some solutions in there for anxiety. I'll come back to this screen and explain it more in detail. I just want to show you on this main screen, you can search by individual side effects, or you can click on the selected drug and you can search on specific, drugs. And it can be a drug or multiple drugs. You can search on Revlimid, and we've been talking about Dex if you want, and say save that. And now you're seeing all the side effects that we have reported from patients that are using Revlimid and Dex. So for example, fatigue, 58% of the patients in HealthTree have reported fatigue as a side effect of Revlimid and Dex. The average severity level over here is a 3. That they have reported. So the severity levels 1 through 5, I believe, is what we have. And the 3 is the average. You can scroll down and see all the different side effects associated with those drugs. It's ordered based on the highest percentage, the most common. So fatigue is the most common side effect for Revlimid and Dex. You can sort alphabetically the side effects if you want, or by severity, where you can see the highest severity levels found with that drug combination. I'm going to remove the drugs and just have the list of side effects again. And I do want to say that I think it was Dr. Hoffmeister that talked about side effects and fake news. This is a patient community-based tool where it is patients that are providing information. So before you do anything suggested in here, you should and need to talk to your doctor about it and make sure they're okay with it, because what works for one might not work for the other. Something that you may be on a drug that would have a problem with maybe some suggestion you see on here. So always talk with your doctor before you try anything that's suggested. I'm going to go into neuropathy, since that's been a big discussion today. And we have 65 suggestions from patients on neuropathy. And you can sort, again, here you've got some sorts, we've categorized them for all solutions. Like maybe if I select physician intervention, I want to see physician intervention solutions, a drug dose reduction, occupational therapy, physical therapy. If I want, let's look up self-management options, acupuncture, CBD lotions or oils, don't smoke, eat healthy. So you can kind of sort. There's lots of sorting options to help you narrow down what you're trying to do or look for. But these are the what we have right now, and you can read through them and see what you think. And if by chance you have tried one of these solutions, it would be awesome if you could click I have tried this solution. We do ask if you know what drug caused the neuropathy. If you say yes, you get a list of drugs that you can select from. If you say no, you can just advance to the next step, and that's where we ask you, did this help? Did it not help? Or did it make things worse? And you can answer that accordingly. And as patients start to come in here and use this tool, these numbers should all change from zero. That's what we want, is for patients to provide this information so that this is a helpful tool for everybody. And, we've got thousands and thousands of patients in HealthTree. How many tried apple cider vinegar? We want that number to show up here, 1,500, 2,000, whatever it is. And then the breakdown over here of if it worked, it didn't work, or made things worse, to help you, figure out how to live with your side effects better. We are going to open this tool up to all of you on this live call. It's not going to be live for everybody until maybe January, February sometime, but we are excited to open this up to all of you that are on the live call right now. That will be available the week after Christmas, so the week of December 28th, and we will send you all an email when you have access to the tool, so that you will know. And we're excited to give you access and for you to use it. And we're also asking for your help in, like I said, clicking on the solutions you've tried so that we can start gathering the data. This is data that we can't research and find. This is personal patient information, personal patient data of if this worked or not. And so this is where we're asking for your help. And one of the reasons we're giving you early access to this tool. So we're super excited about that. If you see something you've tried and it's not on the list, you can click up here to add a new solution not listed below. And you can enter your solution. Again, we ask you if you know which drug caused it. If you do, you can click it and then go to next and tell us if it worked or not. Kind of the same process as if you say, I've tried it here. And then we will get that, and we do moderate them first. And once we moderate them, then we'll push them over here so that it's available for everybody to see. I think those are the basics of the tool. So again, the week of December 28th, everybody that's on this live call, not the recorded, but this live call, we will be giving access to that week, and you'll get an email. And we do ask that if you can, help us start gathering data on here so that all of us can, learn from each other's experiences around the side effects.
Okay, I think Todd too, if you could share under the prior lines of therapy or your treatments that you've received, just so people can see where you include your treatments.
Sure. So in treatments and outcomes, this is where you enter, what treatments you've had or you are on, and people are reporting their side effects to these treatments. And this is where we're getting that initial data.
So the more you enter in your initial treatments or your prior treatments, we then have a team that will go in and validate them. And I think we'd also like to introduce Anna, who is part of our patient experience team, and kind of explain how that process works. So in this process, you can sign a consent form, and then you can we can go gather some of this for you. You can enter it yourself, and then we can validate it on the back end. You can see these check boxes that some of the profile information has been validated. Once it's been validated, it is not editable anymore unless you contact us through the chat, because what we've done is we've measured it, we've entered it based on your medical record, and it's accurate data that we don't want to have changed. So Anna, would you like to share a little bit? And Todd, thank you so much for showing that demonstration of how that works.
You're very welcome.
And Anna, do you want to explain the process a little bit for your team?
Yeah, of course. Hello, everybody. My name is Anna. So what my team does is we gather all your medical information. We help you with that. It's super fun to add all your myeloma information in one place, because then you start realizing when things happen. And we have a really cool chart for labs, and you get to have all your treatments, your genetics. What we do is we invite you to fill out whatever you know, and then we can help you fill out the rest. It's all based on your medical records, so this is going to be accurate data. And once we're done with it, we'll send you an email so you can schedule a call with us, and we can explain everything about your medical information. If you have any questions, or maybe about your genetics, which can be confusing at times, we'll be really happy to explain what all your medical data means. And from that, you'll get different things such as your treatment options, clinical trials. You can fill out your side effects. So that's basically what we do. We're really happy to help you, and we're here, whatever you need.
And Anna's team works individually with patients. So sometimes it might be a 2-hour plus conversation, and sometimes it might be a 5-minute conversation. On HealthTree, you can see a little chat button in the bottom right. So there's a phone number that you can call, or you can use the chat. You can do either one. But Anna's team is fantastic, and they love working with patients, and we're so excited to be continually bringing you these different features inside of HealthTree. So thank you, Todd, and thank you, Anna. And with that, I would just like to thank everybody for participating in today's meeting. This is a topic that I think we could go on and on with, and probably should have another one in the coming year. We are preparing kind of a review of everything that we learned at ASH for our next roundtable, so we'll invite you to join that one as well. We hope to be able to go back to some live meetings next year, but we'll continue this all into next year. And I do want to re-thank our generous sponsors, Adaptive Biotechnologies, Amgen, Bristol Myers Squibb, Genentech, GSK, Janssen, Karyopharm, Oncopeptides, Sanofi, Takeda Oncology, and Foundation Medicine for making this meeting possible. And with that, we wish you happy holidays.